All right. Good morning, Dr. Boyd. Thanks so much for joining us on our podcast.
Please call me Kevin. Yeah, I have a doctor of dental surgery, but I'm Kev, Dr. Kev to the little kids. I'm a kids dentist.
Then Kev it is. All right. So I want to start our conversation by just jumping into, you've done a lot of research on the modern jaw, and I've heard you speak about Darwinian dentistry. So I want to talk a little bit about the differences in our jaws versus our ancestors, what caused it, and why this is important to our health.
You know, it's interesting. I borrowed that term, Darwinian dentistry, from Randy Nesse, who's a psychiatrist from the University of Michigan, now at Arizona, and he has had, he created George C. Williams, an evolutionary biologist in the 90s, this whole area of evolutionary medicine. And so he calls, Darwinian medicine, and he wrote a book called Why We Get Sick. And I just was inspired by him and actually talked to him about creating a branch, if you will, or an offshoot, and just call it evolutionary oral medicine that specifically does the same thing in terms of teaching students, pre-med and medical students, and postdoc training residencies in all branches of medicine about evolutionary explanations for why we get sick. The title of Nesse's book. And well, why do mouths get sick? Why do we get cavities? Why do we get gum disease? Why do we have crooked teeth and poorly formed jaws? So that's kind of where that came from. And I've since learned things by looking at skulls, mainly from the University of Pennsylvania's Museum of Anthropology and Archaeology, studying with Mariana Evans, who is, she was in the orthodontic department when I, with her, joined as a visiting scholar at Penn, and we x-rayed with cone beam, three-dimensional scans in her private practice. We would take skulls out of the museum very carefully with permission and x-ray them, and then compare them, the numbers that we use. It's called cephalometrics, of how orthodontists and other dental practitioners who provide orthodontic services to patients, they use those as norms. Well, the normative values for the lines and angles and how the face should be shaped and the jaw should grow are based upon a bunch of Caucasians from Cleveland area and in other places by a couple of guys, Steiner and Downs, and later a guy named the Bolton brush norms, it's called, from Case Western.
Okay.
So we wanted to compare what we were getting on all of these people who died before the Industrial Revolution in the 18th and 19th century, and to come up with an anthropologically correct base for looking at skulls. So that's how it all started for me.
Okay. And what did you end up finding? I mean, there's obviously a vast difference, correct?
Yeah. And it's not, Mariana Evans and I, we've worked really hard and long, eight or 9 years now, we've been doing this, and it's really informed the way we practice. But there's other people who've done this. Jerry Rose is a dental anthropologist at the University of Arkansas, where I am an adjunct assistant professor there, working in dental anthropology with some of the graduate students. And he's the one with Rick Robley, who's an orthodontist in Arkansas. They worked together and wrote a paper. And what they discovered is that our jaws in the last, maybe a couple hundred years, that sounds like a long time, doesn't it? But considering,
but it's really not.
Well, it's really not. And what we call modern humans or anatomically modern humans have been around for at least 250,000 years. And, you know, in order to survive childhood, you had to have perfect jaws. The foundation for, you know, getting out of childhood was you had to have that. So it's in our genome. But in the last couple hundred years, since the Industrial Revolution, jaws have gotten narrower. They've gotten further back, retrusive, and they've gotten longer. Okay, so our faces have gotten longer, our jaws have gotten narrower, and our faces have gone backwards. So we call that, you know, retrognathia. There's 3 dimensions on how you look at a face, and one is width or transverse. The other one is length, that's sagittal, front to back, and then the other is height or vertical. Okay, so that's kind of, we've confirmed that. That was a hypothesis that had been laid down really in the 50s and 60s, first that I know of by Dr. John Mew, who's an orthodontist in England, who went into the British Museum and looked at old Roman skulls and came up with what he called the orthotropic, which just means correct growth or optimal for health growth and optimal for aesthetics. And he developed the first hypothesis and published on it. I learned from him. I went to England a couple of times and stayed with him and went to his clinic. And Bill Hang is another sort of apprentice, if you will, of John Mew, who's taken it and really provided lots of support for Mew's orthotropic hypothesis and also trained many. I'm a pediatric dentist, but many orthodontists and general dentists are educated by Mew and Hang. That's the broadest base of people who are doing this.
And then, so the Industrial Revolution, how specifically did that impact our jaws? What happened there that's causing everything to get smaller?
Well, we think, and the hypothesis that we've laid out, speculation, if you will, is that it seems to coincide with women entering into the workforce, the textile mills and coal mines, and you know, and what did that mean? Well, an ancestral pattern of nursing and weaning that went on, you know, pretty much for our entire existence as anatomically modern humans, over 250,000 years, was that a baby newborn was immediately breastfed on demand for up to 10 to 12 months of age, is maybe exclusively, but certainly the first 6-8 months, all they had was breast milk or they died. Well, that helped build, you know, what I say is a baby's tongue starting in utero, really about 20 weeks, is responsible for building itself a home to live in for the rest of its life. And that's called the hard palate, the roof of the mouth. So, you know, at about 16 to 20 weeks of age, a baby will start chewing amniotic fluid with their gums, and their tongue will be pressing up on the roof of their mouth and pushing their faces out. We've got, you know, pre-industrial specimens of fetuses that were stillborn. In their jaws, mandibles, everything is forward. So this probably starts in the womb. You know, there's no way you can go back in time and prove that, but we as a proxy, we look at these 400,000 or 500,000-year-old fetuses that their jaws are both forward, the lower jaw. And if you look at, if you have kids and you look at an ultrasound of your own child when 18 to 22 weeks old, many children have chins that are way recessed. And that's something we're really interested that this problem could start in the womb. When we think of an ancestral mother carrying a child, well, you know, she was hunting, she was gathering, and she was walking around, she was breathing through her nose, or she wouldn't be alive. And some of those, you know, we talk about nutrients, vitamins and minerals, and, you know, they were eating natural unprocessed food. That's all there was. And the placenta was delivering that to the baby. But the placenta was also delivering nasally inspired oxygen from the mother, which probably helped not just the long bones grow. I mean, you hear of premature babies that they're short for their gestational age, they're low birth weight, sometimes preterm. None of that. A baby just wouldn't survive if they weren't really well developed as a during their gestation and fetal life. So oxygen is a nutrient, and that's the one that's really the only one that the mother has priority for. The growing fetus gets all the vitamins, and what's left over the mom gets, but not oxygen. And it's just the analogy, I think, is on an airplane when the flight attendant says, if you're traveling with a child, in the event of loss of cabin pressure, put the mask on yourself first and then help your child. Because you pass out, you can't help your kid, you're both going to die.
Right.
So, and it's the same sort of thing and that's a speculation that Mariana and I have developed that we really think. And there's a entity that you see in some of the obstetric gynecology journals called gestational apnea. It's like gestational diabetes or hypertension, that a woman who's not sleeping and breathing well during pregnancy can really rob her baby of that vital nutrient, oxygen, that is required for them, to grow right in the womb. And then it continues once they're born.
So then, if I'm understanding this, the Industrial Revolution, there's kind of this perfect storm happening. So women going into the workforce means we're not breastfeeding like we were. So that jaw development exercise isn't happening in newborns. We're eating processed foods, so our nutrients are changing, as well as everything is softer. And is that somehow also leading to that third trifecta of suddenly we're becoming mouth breathers instead of nasal breathers?
Yeah, there's a lot to unpack there, but you've connected the dots, and I'm impressed, because it is that women, I mean, if they weren't too exhausted when they got home from a 14-hour day in the textile mill, maybe they could do some breastfeeding, and that created the necessity of infant formulas and giving cow's milk. And now we know that cow's milk has maybe 4 vital oligosaccharides. They're sugars that stimulate the immune system. Human milk has maybe 200. But we had to substitute. Wow. And that's, the baby formulas, the purees, the slop. And, a mom, if the formula hadn't been invented yet and the mom wasn't there to breastfeed, they could hire a lactating woman from the village called a wet nurse that doesn't have the same commitment, biologically to a baby that they're hired, to nurse. So it's a combination of, abandoning 250,000 years of what ancestral patterns of nursing and weaning, nursing on demand for about 3 years or 4 years into the 3rd or 4th year of life. On-demand breastfeeding continued, but exclusive breastfeeding usually was done by 10, 12 months. And then the kid was eating every solid that every adult was eating, or they didn't survive. When we were hunter-gatherers, we had to move around, maybe every 2-3 months. And if a baby needed to have their food finally chopped up and pureed, sorry, we can't do that.
Right.
So they're all hypotheses there, but there's lots of support for them in the anthropological literature. Unfortunately, this isn't really in medical textbooks yet, in dental textbooks, but it will be. It absolutely will be. Its time has come.
Got it. So there's really 2 follow-up questions I want to make sure we cover. The first of which is, okay, so now we know we can prove, we're not necessarily 100% sure why. We have hypotheses, but we know the jaws are getting smaller and smaller and smaller. So how is this impacting children? Where are you seeing this in the world of dentistry?
Well, again, it's, you just grow up and the food is processed and, it doesn't require a lot of effort of chewing. And,
Right.
like it starts in early childhood. Well, it also, that means that the jaws, the upper jaw, when connected to the back of the upper jaw, to the hard palate, is the soft palate. And if the upper jaw is too far back, that soft palate can be closer to the back of the airway where the adenoids are. It's a throat tonsil, right? And that can make it difficult to breathe. If the lower jaw is back, and if they're both back, well, that means the base of the tongue, which lives in the floor of the lower jaw, the mandible, that's close to the back of the throat, what we call the hypo or laryngeal pharynx. Pharynx just means throat. And what will happen is the child will switch the natural mode of respiration, which is through the nose. I mean, that's really how we're designed, how mammals are designed to breathe. And they'll gradually go to mouth breathing. Well, there's a guy named Christian Guilleminault from Stanford, who really identified that children can get obstructive sleep apnea, not just adults, in 1976, I believe it was. But his hypothesis was that the adenoid, that throat tonsil, it's a big bump right behind your soft, hard palate, is that what happens is kids gradually start mouth breathing for a number of reasons. Well, when that happens, you get pathogens from the air coming in, and the nasal sinuses, which when you breathe through your nose, you kill all that stuff, and you warm and humidify the air, and you also release something called nitrogen oxide, which opens up blood vessels and facilitates oxygen getting into the bloodstream and to the heart, to the brain. Well, that gradually, as kids start to mouth breathe more and their jaws get further back, then the adenoids start to grow, and that just exacerbates, makes it worse. And the general theory is, that's accepted in most medical textbooks, is that the enlarged throat tonsil adenoid is what causes the mouth breathing. And it's sort of like Guilleminault said, maybe not. And this is my hypothesis. So gradual nasal disuse is what he called it. And then, the face will get long. In fact, the medical profession calls a kid with a long face, and dark bags under the eyes, they call it an adenoid face. Adenoid face.
Adenoid face.
Long face syndrome.
And that's all from mouth breathing, because as you breathe, it impacts your face.
It influences the way your face will develop, and your face is connected to what? Your airway. We say that the back of the face is the airway, or the front of the airway is the face. So the position and shape of your face is sort of a proxy for what your primary mode of respiration is. It's not 100%, but it gives you an indication. There's things we can look at. So
okay. So then it's impacting the way that children are breathing. And is it this new pattern of breathing, the mouth breathing, is that what's impacting their development physically and mentally?
Yeah, absolutely. Like I said, how often should you breathe through your mouth? And my colleague Karen in Grand Rapids says as often as you eat with your nose. Okay, so you don't eat with your nose unless you're tube fed in a hospital, but no, nose breathing, your tongue should always be in the roof of your mouth, except when you're eating. And our ancestors used to eat and chew all day long, so the tongue spent a lot of time in the lower jaw developing it along when they weren't eating. Talking and forming consonants and click sounds. Our ancestors in Africa talked with clicks, and if they couldn't do that, they died. It's a survival mechanism.
Right.
So chewing and breathing through the nose, they develop both jaws, and but the tongue at rest should never be anywhere but in the roof of the mouth.
So how does breathing through your mouth, though, impact, just so people understand, how does that impact your brain and a child's brain development?
Well, the same thing is that you have to breathe in a lot more air when you're doing it through your mouth to get it, sufficient quantity, 100 milligrams percent to your brain. You have to breathe, overbreathe or breathe faster, take in more volume of it, which coincides with systemic inflammation. Nose breathing, again, the most powerful antioxidant on the planet is nitrogen oxide. And, that's in the lining of your sinuses. So when you breathe through your nose, you've heard of something called turbinates. Turbine is the root word, like in a jet engine. It causes turbulation of the air, which is a catalyst. It sparks the release and formation of nitrogen oxide in the sinus lining. It's L-arginine is an amino acid that is released and turned into pre-nitric oxide synthase, which makes this, and it kills. It's an antioxidant. It's an antimicrobial, and then plus from nasally inspired air, it warms it to your body temperature. The ambient air is maybe 70 degrees, unless you're in a rainforest, and it's not humidified. I mean, our bodies are like 3/4 water. Well, the dry, cold, dirty air gets warmed, humidified, chemically filtered, and mechanically filtered. So that delivers much more efficiently oxygen first to the heart in the hepatic portal system, we call it. It's cleaned by the liver, and then it goes to the heart and it goes to the brain, and you're getting, this beautiful, efficient delivery of oxygen that and it can impact the way a brain grows, even, gray matter. Dr. Gozal and his wife have published on this, is that, the cortex of the brain is affected by mouth breathing versus nose breathing. And behavior, attention, intelligence can knock points of IQ off some kids if they're mouth breathers, habitual mouth breathers, and don't cycle normally through the stages of sleep. So that's the whole neurological connection there to breathing.
Got it. Yeah, and you touched on behavioral impact, and I like to talk about that a little bit. You introduced us at CAF to the Dunedin study.
Yes.
Which I thought was incredibly fascinating. So would you mind explaining a little bit of that to our listeners?
In 1970, toward the end of 1973 and early 1974, every baby that was born at the Central Hospital in Dunedin, New Zealand, 1,037 of them they had funding for like a 4 or 5 year study where they would follow them and do metrics on them and measure their height and their weight and their, believe it or not, their dental health, their sleep, and agility, APGAR scores you may have heard of, but that's neurological when a kid's born. But it's kind of like that, and they would do this periodically over 3 or 4 years. Well, it was going so well that they got more funding to continue it. Even our National Institute of Health in America invested in this, and now over 1,000 of these babies are still participating. They're in their 50s, 60s, if you will. I don't know, do it from 73 to the 50. They're in their 50s. But what they found is just incredible. I told you they took dental data. Well, they were looking for cavities and gum disease. And then, the orthodontists looked at them at 12. So there wasn't really anything about the dentofacial development that goes in here, but there was sleep. And one of the things that they found is that children before the age of 11, if they demonstrated self-control, impulse control, and they had metrics, validated metrics to gauge this, they, in their 30s and 40s, looked 10 years younger. And, I'm going to show, maybe just one slide, not to you today, but of where they'd done composites of these babies that demonstrate, the marshmallow test. You've heard of that? Where they
I have.
like that. Kids kids who really could do that, and they didn't do the marshmallow test. They had other ways of estimating a child's self-control in the 70s and 80s. But these people, they found in this, if you just Google Dunedin study in self-control, what you will find is amazing, is they not only looked younger, but they were resistant to systemic illnesses like cardiovascular disease and type 2 diabetes and obesity, wealth management, attaining educational level, criminal and addictive behavior, almost non-existent in these kids who exhibited self-control before the age of 11. And sleep was one of the things that they measured. So I am like so excited about this, and to be able to, talk to parents and introduce something called health span. Everyone knows lifespan or life expectancy from birth, right? Well, now it's in, 78, 79. It's gone down a few because of the pandemic, but how long do you stay healthy into your extended lifespan? And the conjecture and the what we're projecting from the data from the Dunedin study is that having this ability of self-control before the age of 11 not only projects optimistically for an increased life expectancy, many of these kids will probably, according to some of the investigators on this trial, will live to be 100 years old, and they will stay healthy into their extended lifespan. I mean, wouldn't that be the greatest?
That's wild.
95, get sick one day and drop dead, and be able to be healthy in your old age. That's health span. We've got to get that point across. And I think that's really what CAF, my contribution is going to be, to really try to raise awareness about the possibilities of not just building beautiful faces but the whole thing. If a child can nose breathe as early in life as possible habitually, I think it's reasonable to be optimistic that they're going to have a better quality of life immediately and an extended lifespan and health span, quality of life all the way through. Anyway, that's the goal.
That's wild. I love this study. Yeah, and I'll make sure to include a link in our show notes as well, so people can check it out, because it really is. It's fascinating, absolutely fascinating. So when we're talking about smaller jaws in children, at least in my conversations, at some point retractive braces pop up, because now, over the last year, we've heard a lot about retractive braces and why that can be dangerous for children with undiagnosed airway disorders. So I'd like to chat a little bit about that and get your insight on that. Really, first of all, just explain to parents what that is and why that's dangerous, what they should be looking for.
Well, right away, people use interchangeably braces and orthodontia, orthodontic treatment. And it's really the American Association of Orthodontists changed the name of their journal from the American Journal of Orthodontics to the American Journal of Orthodontics and Dentofacial Orthopedics. Now, dentofacial orthopedics, that implies that the airway is going to be involved, because what's the face connected to in the jaws? The respiratory system. I mean, also the auditory, visual, olfactory system. There's all these survival mechanisms. But if you change in straighten teeth, well, braces implies permanent teeth. You don't put braces on baby teeth, right? So the implications, orthodontics doesn't start till there's permanent teeth. Well, usually by 8 years old, a kid will have 12 permanent teeth. And then, an orthodontist can be really aggressive and, really proactive and start treating at 8. Well, I call 8 years old a geriatric patient in my practice. You can begin optimizing the craniofacial connected to the respiratory complex. Mike Mew calls that craniofacial dystrophy, but I like to get the respiratory aspect into that. So I call it the craniofacial respiratory complex. You can start optimizing not only the form, but the function of those interconnected survival mechanisms, the craniofacial complex and the respiratory complex, you can start optimizing the hard and soft tissues, hard being bone, soft being muscles and vasculature and fascia, all these other tissues. You can start optimizing them. Are you ready for this? Like
Yes.
at birth. I mean, nursing.
What?
Breastfeeding is a dentofacial orthopedic appliance. It starts helping the tongue. If you watch a video by Donna Geddes, who Geddes in Australia at Perth, she did ultrasounds of babies breastfeeding and showed how the baby's tongue will push against the mother's nipple up into the sutures. You know, the fontanelles on the baby's head, the soft spots, those are all over your face and all over your jaws. And the baby's tongue will push the nipple and create a vacuum and push forward, and all these palatal facial sutural complex, I call it, or fontanelle complex, they all start developing first in utero, like I said, with the action of chewing amniotic fluid. But then when they're born and they start nursing, and if a mom can't nurse, cup feeding is better than giving an artificial nipple unless it's to save the kid's life. But preemies can even cup feed. They do that in some nurseries. There's studies on that. But certainly introducing something called baby-led weaning, but not overly commercially processed foods, but stuff that kids can chew on. They can chew a pork chop at 6-8 months of age. If they can sit up, they can baby-led wean. Well, all those things start dental facial orthopedic development. Okay. Well, then when the child has 20 teeth, and even, before that, but usually by 2.5, 24, 28 months of age, a child will have 20 teeth. Well, Journal of the American Medical Association, December 1922, an article by Cohen talks about how 30 to 32 months of age is the ideal time to start palatal expansion in a child for respiratory advantage, not for straightening teeth, for respiratory advantage.
Wow. 1922.
1922. And I'll send a link to that article, or you can download it and anybody can read it.
Yeah, we'll definitely put it in the show notes.
It's not random controlled trials. These are, you didn't have evidence-based medicine until after World War II. They were observational trials, like Einstein. He discovered relativity not by doing a random controlled trial. It was a thought experiment. He was riding his bike in the turn of the last century and imagined himself overcoming the headlight beam on his bicycle, and he would turn into energy. That's how he came up with E = MC². It's an observational study. Scurvy, vitamin C, all those things were cholera as being a waterborne rather than an airborne disease. A book called The Ghost Map, excellent, by Stephen Johnson, talks about all that. But, these are observation, and the 1922 JAMA article talks, it's based on controlled observational studies. Came up with that.
Okay. So then with regard to braces, I mean, obviously they have their place, right? There are benefits for straighter teeth. As a parent, I go in with my 11-year-old, the geriatric child, which I love that. So I go in and I'm told that there's not enough room in my child's mouth, and we have to remove all these teeth, and we're going to do braces. As a parent, is there something I should ask? Should I be concerned? How do I know that that's going to be okay for my child, not do more damage if they have an undiagnosed airway issue?
Well, most orthodontists don't really consider the airway complex as being all that intimately related, to the craniofacial complex. So that's something, and it's not their fault. It's the curriculum. The curriculum does not teach anything really about it. Now it's starting to, maybe. orthodontists are also not taught anything about child development, behavior guidance, anxiety control. I'm a pediatric dentist. Are you kidding? That's how I make my existence worthwhile, how I stay pertinent to the profession, is I know how to understand a child's fears, anxieties, curiosities. Most of them are just curious, and they're maybe threatened by a novel clinical setting. Well, I had to demonstrate extreme competence in that before I could get board certified in pediatric dentistry. And at the University of Iowa, you don't get a certificate unless you're competent in managing anxiety of children and their parents. They don't learn that in orthodontic school because it's implied you're not going to need those skills because you're not going to see them mostly till they're about 9, 10, or 11 at the soonest. They say, do the first visit by age 7, but that doesn't mean start treating by age 7. More on that later, but I'm just
first orthodontics visit by age 7 is what you're saying?
The AAO, American Association of Orthodontists, has a pamphlet that they renew every couple of years, and it just says first orthodontic visit evaluation should be no later than age 7. But it says in the same brochure, but most treatment won't begin, till they're somewhere between 9 and 11. And to me, so I in answer to your question, like, well, if they say the teeth don't fit, and how do I make them fit? Well, what if you go to a shoe store and I wear a size 8, and they bring out a size 6, and it's like, well, you really like these shoes, Dr. Kev. We're gonna have to cut off some of your toes, but they'll fit. You'll have them, and it's like that's ridiculous, right? Or
right.
even for a third-year dental student, depending on where they train, he can look at a kid with no space, a 3-year-old, 4-year-old with no space between their teeth, and they'll say, save up your money for braces. And that's like an endocrinologist or a pediatrician telling the parents of a kid with high blood sugar, save up your money for an insulin pump, because guess what? Your kid is going to be a brittle diabetic, and maybe, or an ophthalmologist telling the parents of a nearsighted 4-year-old, save up your money for glasses. You don't want to do it now. It's too early. Wait till they're driving a car. Then you'll save a lot of money and you only have one prescription, right? That is a sound analogy. That's medically defensible, what I just told you about myopia anyway. The diabetes thing is a little extreme, but myopia, nearsightedness, that can cause the same neurological issues as mouth breathing. A kid can be psychologically damaged because they can't see, and they behavioral issues, even cognitive issues. Are you kidding? They can't learn if they're not seeing. It used to be the chalkboard, or they can't.
Right.
So anyway, I digress, but that's kind of the 11-year-old. You can't go back in time, but no, don't. You want your kid to have, in 3 dimensions, you want them to be wide enough so their tongue will fit. You want them to be forward enough so their tongue will fit. And you don't want them to be deficient in vertical, like deep overbite, or excessive, like long face. All right. You want all 3 dimensions to be optimized. It's harder to do in an 11-year-old, but you can prevent things from getting worse. But if you take out teeth and then you put them in headgear that pulls things back and everything, you're going to take a suboptimal situation and you're going to make it worse by doing retractive orthodontic procedures, dentofacial orthopedic procedures.
So would this be a good opportunity then as a parent, if, this is what you're presented with and you suspect, you've done some of the things we've talked about in previous podcasts, watch your child sleep. So, they're a mouth breather. You figured out they have sleep apnea because they're snoring. Would this be the right time then to say, what, before we go down this path, I'm going to take my child to an ENT or an airway centric dentist before you do anything?
Yeah. First of all, snoring doesn't mean a diagnosis of apnea. It's sleep disordered breathing. We call that apnea. Snoring is, sort of on one end of the spectrum, and end stage is apnea. And that has to be diagnosed with an overnight polysomnograph or a sleep study.
Okay.
And I don't make direct referrals, even though I can. I'm on staff at a tertiary care children's hospital, but I always go through the primary care physician, which is the pediatrician.
Okay.
Is that,
Mhm.
I do work with the sleep medicine service at Lurie, and I know a lot of the ENTs, but is there anybody you like referring to? Because our mutual patient, and you're the primary care physician, I'm the primary care dentist, or, somebody else is and they referred to me. I want to introduce that into the lexicon too. PCP is primary care physician. Everybody knows that. But
Right.
how about PCD, primary care dentist? Because many of us, I'm a pediatric dentist and I can do all phases of dentistry for kids, but I've really just narrowed my focus to dentofacial orthopedics on kids in the primary dentition. That's just because nobody else really wants to do it or isn't yet doing it as much. So I call the referring pediatric dentist or the family dentist, general dentist, I call them PCDs, primary care dentists. And
Okay.
just so, you as a mom, yes, you want to talk to your pediatrician, but you might be the one that's going to, say, look, would you please look at this? There's a flyer from the American Dental Association, and I'll send it to you when we hang up. But everybody, you can just, I give it to parents, and you can give it to your pediatrician, give it to your primary care dentist. I'm on a task force at the American Dental Association, the Pediatric Airway Task Force, Airway Health Task Force, started by Stephen Carstensen. And we're coming up with our own screening tools for dentists and physicians to use, in addition to the pediatric sleep questionnaire. But it's written in very plain English. And you could be the one that could change the course of that dentist's career. Oh my gosh, I had no idea. I didn't learn any of this stuff in dental school. I didn't learn it even in my pediatric dentistry training. And I went to one of the best programs in the world at the time, University of Iowa, in the late 80s. And I learned that retrognathic chins at 4 years old are always going to be retrognathic. Sam Bashara, famous orthodontist, taught us that, but he didn't really say anything about breathing. He just said, look, once a class 2, always a class 2. He's the one who taught me that. And it's true. It's defensible. Is that, jaws are too narrow, maxillary transverse deficiency, with or without a crossbite, cannot self-correct. It cannot self-correct. It will persist. It will usually worsen, and either is or will become a comorbidity, we say, with sleep and breathing disorders. So width, height, and length all need to be optimized as early in life as possible to assure a child has the best chance to be a habitual nose breather as soon in their life as is feasible to do so. I mean, if I meet a kid at 12, that's the earliest feasible time I can try to optimize it. But as a pediatric dentist, I'm seeing them before they're age 1. I'm even looking at
Really?
Yeah. Oh, yeah. That's the American Academy of Pediatric Dentistry. All children should have their first dental visit by age 1. The American Association of Orthodontists, they should have their first orthodontic evaluation by age 7. So no, this is something that needs to be understood by everybody in healthcare. And you don't have to be someone who even sees kids. If you're somebody like a prosthodontist who makes dentures and does implants, well, guess what? You're treating the grandparents and great grandparents of little kids who may have sleep and breathing disorders. And the information may come from you, Grandpa. I hear, your daughter just had, or your daughter has a 2-year-old. Why don't you ask her if he snores? I mean, there's so many ways we can all share knowledge and information. And really, it's the general public that's going to cause policy change. And what I say is angry moms, boy, I've had so many moms when I'm consulting. And when I tell them, they've already had an orthodontic consult. Oh, they said, wait for the adenoids to shrink and all this. And then I tell them what I think after I show them, the cone beam x-ray, and they'll go, I thought so. I thought there was something wrong here. I thought there's something that could be done. Maternal instinct is the most powerful force on planet Earth, I think. And, you know, I don't have many people disagree with me, especially husbands. And they'll stand back and say,
as a mom, I'm obviously going to agree with that.
Yeah.
So, and it's funny because one of the things I was going to ask you is, you know, how do we, you know, turn the ship and change the course of really medicine, how it's working, how dentists and pediatricians are being taught, or in most cases not taught this information, and how do we get it to parents? And you already touched on part of it is advocates. I mean, we have to be our kids' advocates. We have to trust our guts. We have to ask the questions. We have to do the research. We have to fight for our kids. So how do we handle the other part of that equation as far as just medical practice? We have the, you know, up and coming pediatricians and dentists. How do we get them this information and just change the course we're on?
well, I just feel it's the curriculum. It's the healthcare professional curriculum, the medical school curriculum, the dental school curriculum, the dietetics curriculum, the speech and language pathology curriculum. All these, they all need to change. They all need to be influenced by this. And we can't work alone. I mean, everybody needs to be talking to each other. The OB-GYNs, they need to understand gestational apnea. I know more about gestational apnea than a lot of obstetric gynecologists. Why? Well, I mean, it's all over their literature, but they don't, you know, they don't read. I don't read everything in the dental literature. There's things there that I discover every day. But it really is, and not being judgmental. Like, it's like, oh, the orthodontist, they told me they want to pull teeth and all this, and I used to like be judgmental, and it's like, wait a minute, I just learned this a minute ago. This hasn't been a career. It's been 12 years now, but I spent a long time not knowing anything about this, and now all of a sudden I'm going to judge other people who haven't been exposed.
Right.
So that's part of it, is that we have to be understanding and raise public awareness, and that's, again, policy change, and really the curriculum, the educational curriculum, teaching modules, integrating it into an existing base curriculum, slowly, gradually. There's a couple of, I mean, this is, the partnership that CAF has, with Dell and in Austin at the University of Texas, and the medical school and the dental school, and Leah Harris. I mean, there's just so many good things, connections that can happen here. I'd love to be invited to lecture to ENTs, and I have been at Loyola University Medical Center here where I went to dental school, but I got invited to do a grand rounds in the ENT department. It was invited by the head of ENT. It was great. So that's the sort of thing that we have to cross-disciplinary, cross curriculum activities. And UT Austin's going to be a leader in this. There's another institution that's
I think so.
Something similar.
Yeah, I agree. So as we wrap things up, I always like to give our guests the opportunity to speak directly to parents and just, leave them with something. What is it that you would tell parents specifically around airway health and, how to do the best for your child in this, the environment that is life today?
There's many things you can do to optimize your child's quality of life, which it also enhances family quality of life. I mean, what parent has a good quality of life if their child doesn't? And one component, in addition, to getting them, square meals and shelter and education and physical activity, all those wonderful things that parents can assure that their child get, is the ability to breathe through their nose habitually while they're awake, and especially while they're asleep. How do you do that? Well, you know what? You need to know that should be done. how it's done and the nuances, pretty soon will be as public knowledge as is eating fresh, minimally processed food and not, living in front of a computer screen and video games, but being outdoors and playing. That's sort of, in the public domain now. But this sleep and breathing thing, as early in life as possible, this is just not out there. Air is air. I still have some healthcare professionals. Well, it's oxygen. I mean, what difference does it make if you get it through your mouth or your nose? It's getting less and less, but most people, they'll say, oh yeah, you should breathe through your nose. But I just don't
They
think
don't really understand.
it's ubiquitous in healthcare and the public domain as well yet. And that's really what we need. That's what we tell parents. Your child needs to be a nose breather immediately, as quickly as possible. And we have to find out why they're not, if they're not. First, find out if they're not. Maybe they already are, but that's another thing you can feel good about.
I love it. Thank you so much for being with us today, Dr. Kev. I really appreciate it.
Oh, and thank you. Very skillful in your questioning and interviewing. I enjoyed it very much.
Thank you.
Okay, Rebecca.
Done.